Living with a chronic respiratory condition doesn't mean giving up the things you love to do. At Blue Zone Health, we're here to help you breathe easier and rebuild your strength. Our online cardiopulmonary rehab program offers tailored exercises, self-management training, and expert support from certified respiratory therapists. Accessible anytime, it's designed to reduce breathlessness, improve lung function, and empower you, all while connecting you with a supportive community. Visit bluezone.health and take the first step towards stronger lungs and a healthier future. Blue Zone Health. Breathe better, live better.
Hello, everyone. Welcome back to the Cozy Lung Lounge, where you get to hear all kinds of good information. Today, we've got a special guest that was requested by one of our viewers. I'd like to welcome our guest speaker, Joni Colle, who's speaking about surgical options for lung disease. Joni is a respiratory therapist and registered nurse who has spent the majority of her career in pulmonary rehab. She appreciated the longer-term connections she created with pulmonary patients in that setting. She's been able to build similar connections in her work, coordinating the lung reduction program with the SIU Cardiothoracic Surgery in Springfield, Illinois. We are excited to have her to share her experiences with lung volume reduction surgery and Zephyr endobronchial valves. That's a lot of big words. There's lots of new words tonight. So thank you for coming, Joni. I look forward to hearing you.
It's great to be here. This is a fun format, something new for me, and I'm just honored to have you ask me to speak and that somebody requested me. That's kind of scary.
Well, thank you so much for being here. I think surgical options is not something that people normally think of when they think of having a pulmonary disease or having some pulmonary health concerns. So this is a really interesting topic, and this isn't something I know a whole lot about as an exercise physiologist. So I'm really excited to hear what you know and to hear all about these things.
Yeah, so I spend a majority of my day screening patients who call in wanting information. So I thought I would just use that kind of format to explain this, since our population may mostly be patients. I take phone calls from people all across Illinois and a few nearby states, and it's just really interesting. Telephone screening is how I start, but just to kind of backtrack a little bit, what we're talking about is a treatment for patients who have COPD. We use that as an umbrella term, but I want to kind of whittle that down, pare that down into specifically talking about emphysema, because that is really what we're treating. That is a chronic obstructive lung disease, chronic obstructive pulmonary disease, COPD. But emphysema that we're dealing with, I would say the majority of patients that I talk to, probably 99% of them have developed emphysema from having a very lengthy history of smoking cigarettes. And that is generally the history that I get from them, that they started smoking when they were teenagers, or at least as young adults. So we're talking at least 40 or 50 years of smoking, one pack a day, mostly for people. So at least anywhere from a 25 to 50 pack years smoking history for most of the people. And so they have started to seek out some way of, how can I improve my quality of life? How can I breathe easier? You know, I have a lung doctor. They're taking good care of me. I'm on a lot of medications. Some people are on oxygen, other people are not. But basically, when they seek out our program, they're looking for a way to improve their quality of life. So I just kind of give that as an introduction.
What is the difference between emphysema, chronic bronchitis, and COPD?
Well, I see COPD as being like an umbrella. It kind of incorporates all of those things. We usually speak about having underneath that umbrella emphysema and chronic bronchitis, and maybe asthma, but asthma in its purity would be in a separate category. But some people can develop this COPD asthma overlap syndrome now, which is becoming kind of a hot topic as well. But chronic bronchitis is where the patient may have a smoking history, but they present with a production of mucus for 2 to 3 weeks out of the year, usually in the same couple of months of the year, and it kind of repeats itself so that the patients are creating more mucus. They have inflamed airways, and they're coughing up a lot of sputum, and so that kind of puts them in a separate category, that chronic bronchitis. It never really goes away. It may subside or get a little better certain months out of the year, but then it kind of rears its ugly head again, and then people don't feel very good. So that would be chronic bronchitis. But with emphysema, we're talking about the damage that is done to the airway, but more specifically at kind of the end of the airway are these little air sacs. And I always kind of use my hand as an air sac. And with the emphysema, they're like little balloons. We hear a lot about the heart, and the heart and the lungs work together. The heart's a muscle. The lungs are not a muscle. They're very fragile tissue. It's very fragile tissue. We think of our lungs as being pink. I think of them as being a conglomerate of a lot of little teeny tiny air sacs or a bunch of teeny tiny balloons. Going back, Gina, to RT school, we learned that there are 300 million air sacs in a normal lung, and they're very small. If you were to smash them, if you were to smash this air sac and flatten it out, it would carpet a tennis court. So you have a lot of surface area that is important for the exchange of bringing oxygen into your bloodstream and then releasing a waste product, carbon dioxide. So as this air sac wall is damaged through years and years of smoking, in its healthy state, it's like a balloon that you've never blown up before. And if you've got children and you've had to blow up a balloon, or grandchildren, that first blow up of a balloon is really pretty difficult. You have to overcome that elastic recoil. But think about that same balloon. If you've kept it around, if you continue to blow it up, it gets easier and easier because the elastic tissue is lost over a period of time. I even think of like these helium balloons that you see, that eventually there's kind of stagnant air that remains in the balloon. It never really goes out. And that's what happens in emphysema. There is a loss of elastic tissue, recoil in those teeny tiny air sacs. They even sometimes lose their alveolar wall. They lose that balloon wall, and they start kind of forming together. So what was once teeny tiny now becomes this large, gaping kind of big balloon that we can see on CT scan, not so much on X-ray, but I look at CT scans every day, and you can see that degraded alveolar wall, air sac wall that, once was maybe small, but now it's this large area of emphysema. So that is what we're treating with both types of lung reduction. And I've started to kind of coin the phrase of us having a lung reduction program, surgical versus endobronchial valve. So one is a surgery where we're actually removing tissue. The other is an endobronchial valve where that trapped air is released. Now, I know I've gotten a little ahead of myself here, but I do have some pictures that I sent to Amy, and I think there's a first one that says, what is emphysema, Amy? Can that one pop up?
Yes.
There, perfect. So if you look at this picture, I think it's kind of a nice little cartoon picture of our lungs. If you kind of even can drill in and see the character on the right-hand side, you can almost visualize kind of those teeny tiny air sacs there. So if we look on the left side, you can see the lungs, they're pink. If you know your anatomy, in the center, there's a trachea or windpipe. It branches off into the right lung and the left lung. You can see those airways there. That is how the air travels in and out of the lungs. So we have a right lung and a left lung, and at the bottom, that kind of orange line that's there. Yes. Ooh, we've got a pointer. Very good. Is the diaphragm, and that's the large muscle that is at the base of both of the lungs. It's really responsible for doing about 70% of the work of breathing. So as a respiratory therapist, Gina, you know, we always talk to our patients about breathing from your diaphragm, strengthening your diaphragm, using that to really do the majority of breathing, the work of breathing that kind of eases shortness of breath. But if you look at this character on the right-hand side, you can see that that diaphragm is flat. It's not domed up like on the other picture, and the trapped air in the lungs, that you can see that the pink lung tissue is much larger. It's because there's a lot of air trapped. Those air sacs that we talked about are holding a lot of extra air than what they would in a normal healthy lung. So as additional air is trapped in the lung, then the lungs become what we call hyperinflated. So that's probably the primary criteria for being able to be a patient that would be evaluated for one of these lung reduction processes. We're looking for hyperinflation. You can see it on a chest x-ray, but you can get a more detailed view of how much air is trapped on a CT scan. And that is, patients might know it by the terminology CAT scan. So we get a CAT scan of the lungs initially, and we can look to see the destruction of the lungs in those air sacs. And then the second thing that we would do would get some pulmonary function tests.
I have a quick question, Johnny.
Yes,
So when
sure.
they're doing the lung volume reduction surgery now, are they doing this robotically? Are they doing it through the small incision now?
We do, our surgeons do a lot of robotic surgery. And, when we first started the talk, we talked about surgical options. And I think a lot of people know about lung surgery in the setting of lung cancer, where people have a lung cancer removed. And I do know they're doing some robotic surgery that way, but we have not done this lung volume reduction surgery robotically, but we are doing it with what we call VATS, VATS, video assisted thoracoscopic, where 3 puncture holes are made in between the ribs underneath the armpit on each side. And so it's a little less invasive than we know how open heart surgery is, cutting through that sternum bone. And it's pretty rare that our surgeries are done that way anymore. I know in years past, Dr. Hazel Rigg did do median sternotomy, and I think if they feel like they have to really be able to see inside of the chest, they'll do that. But I think that's pretty rare that we use that procedure anymore.
I know years ago it was the sternotomy, but now, a lot of people are using the VATS, which is much, much less invasive and a much faster recovery time.
Correct.
So anybody who's listening, I just want them to understand it's
Right.
a lot cleaner and faster today than it was 5, 10, even years ago.
Yeah.
Tell us more.
So that would be our next segue. So if we talk about the surgery, what is lung volume reduction surgery? Well, it is the surgical removal of that diseased area of emphysema. So to get to this surgical point, patients have to have that CT scan that reveals to the surgeon that the majority of their emphysema is in the upper portion of their lungs. And when I talk to patients on the phone, even though they can't see me, I will tell them, if you take your hands and you find your collarbone and you just place your hands right below your collarbone, that is the area of the lung that we're talking about. A lot of the emphysema will find itself migrating to those upper lobes of the lung. Is it because smoke rises and that's where the damage is? I'm not really sure. Sounds like a practical answer to me, but patients can either have an upper lobe emphysema that we call heterogeneous, or they can have emphysema that really goes throughout the lungs. And if they have that type of emphysema where the smoke or the damage, the emphysema is just throughout the entire lung itself, through all of the lobes, we call that homogeneous or diffuse, and those people generally are not a candidate for the surgery, because the best outcomes are when those bilateral upper lobes are removed, and then the patient recovers with the remaining amount of the lung, can move up into that space, and then the diaphragm that you see here on this little white picture, the diaphragm then can move up after that volume of diseased tissue is removed. So it gives space for the remaining part of the lung, which may not be perfect, but it's healthier. It's the better part of the lung. It may still have some emphysema in it, but then that is allowed some space to move up, so then the diaphragm can move and all the mechanics of breathing and the work of breathing is alleviated. So reducing air trapping and reducing hyperinflation would be the purpose of the surgery. But like Kelly said, it's a very rigorous process. It's not as invasive as it once was because of using this VATS type approach. So that's the surgical side of things. You have patients presenting with pulmonary function results where we're looking for people that have a residual volume of at least 150% for lung volume reduction surgery. So we're talking way over 100%, normal being maybe 80 to 100%, but we're looking for that to be at least much larger. So 150 for lung volume reduction surgery. And then as we move on, we like to see a larger residual volume or leftover volume for even the endobronchial valve. So when I say residual, that word by definition is leftover. So that is the portion of the pulmonary function test I explain to patients that when you're in the telephone booth or the body box and they close the door and they're asking you to blow all of your air out, you've done a variety of maneuvers, but this is a maneuver where the respiratory therapist is asking you to take a deep breath in and then blow everything that you can possibly blow out of your lungs. You're in a contained box where the pressure and the volumes remain constant, and you're blowing until you feel like you just cannot blow any more, almost to the point of, a lot of people say, I felt like I was going to pass out. I mean, it's that kind of effort that goes into it to measure this residual volume. And then when you feel like you can't blow any further, the respiratory therapist knows the ideal point and they block that valve off. And then at that point, the volume of air that remains in your lungs at end exhalation is then measured. It's the leftover volume after the patient has totally blown out all of the air in their lungs that they could possibly blow out. So when those air sacs don't allow the air to blow out, meaning that there's obstruction to airflow out, the definition of COPD, it's an obstructive lung disease, then that volume inside of the lungs is what our surgeons are looking for, to have, at least 1 to 2 times the amount of leftover air in the lungs, because we know the higher the volume that's trapped in the air, the more that we can reduce it, and then the patients feel the benefit more. If you just have a little bit of residual volume and we reduce that, the patient is probably not going to appreciate much of a change in their quality of life. They're not going to feel the improvement in their breathing if it's just a small amount. So a lot of times people come and they'll say, I'm not bad enough, or I'm not sick enough, but we follow them and we watch those pulmonary functions. We stay in contact with their pulmonologist, and it, as their disease could possibly progress, then we can always reevaluate them. But it's always beneficial to kind of get that information so we can see where people are.
Hi, I'm Kelly, a registered respiratory therapist with Blue Zone Health. Do you feel breathless much of the time? Are you unsure of how to manage your breathlessness? Is it keeping you from doing all the things that you would like to do? I'm here to help you learn to work with your healthcare team to come up with a plan that will work for you. There are lots of tools, tips, and tricks and breathing exercises that you can do now that will help you breathe easier and more effectively. I look forward to joining you on this journey and empowering you to breathe better.
Absolutely. And what would be maybe some of the risks to this surgery? Because I know it's important to stay informed as well when you're comparing the two and deciding what you want to do.
Yeah, and that's one of the things I think that's unique about our program. I'm working with 2 cardiothoracic surgeons here, Dr. Stephen Hazelrig and Dr. Travis Crabtree. And when a patient even calls for endobronchial valves because that's what they've heard about on Facebook or from a friend or from a respiratory therapist somewhere, we will always evaluate them because we have the capability of doing this surgery. So we'll evaluate them for lung volume reduction surgery, and we'll evaluate them for the endobronchial valve. When we meet with them, we'll go through all of their test results and give them the risk and benefit of the surgery, if they're a candidate for that, the risk and benefit from the endobronchial valve. So we can present both of those avenues of their choice and collaborate with them and the surgeon, so that it's a team decision. We never push anybody into having surgery or having a procedure, but it has to be something that they want to pursue if we feel like the benefit is greater than the risk. So back to that, to answer your question, really, I tell people that if we're choosing the surgical route, I really want them to be as strong as they can possibly be, because probably the biggest risk after this surgery is developing pneumonia. And that has happened. We work really hard for that not to happen, but we do that by preparing the patient and having them complete a full course of pulmonary rehab, outpatient pulmonary rehab. And that's really my background. I feel really strongly about patients who have emphysema, trying to exercise on a daily basis. And I know if the audience out there is listening, has emphysema or has shortness of breath, they're probably going to say I'm crazy. They've probably told all of us that. How in the world do you expect me to exercise when I'm short of breath? Well, it's interesting because I just had a conversation with a patient today that we prescribed pulmonary rehab for him. And I will tell them right up front, I want you to complete for the surgery 16 to 20 monitored, we call that phase 2 exercise sessions in pulmonary rehab. And I want you to take that time, those sessions, those 16 to 20 sessions, which is going to take you at least a couple of months, maybe even 3 months time, depending upon how often that hospital program offers people to come, how many days per week, and gradually work your way up to walking 30 minutes on a treadmill. And, you know, people just look at me like I'm a man on a moon or something, but I've been there. I've stood right by the treadmill. I've coached people. I've had a cup of water with a straw if they needed a drink. I've held a fan in their face. We've turned the oxygen up. We monitor their pulse oximetry. We, just really encourage them. And minute by minute, we increase that with every session that they're there. And I just talked to this gentleman today, and he said, I didn't believe I could ever do it, but I've done it now for 8 sessions. I'm walking 30 minutes. And it's such an accomplishment, and it's such, they feel so proud of themselves. And that's just one of the things that I enjoy and I appreciate about all of our respiratory therapists and exercise physiologists, Amy, that are there in that arena helping those people exercise, because we know that, walking is life and patients have to walk. They have to walk to the bathroom. They have to walk to the kitchen. And it's just, very good. And that's all we have after surgery. We just have walking. People will say, well, can I ride a bike? And if I don't know what your theory is, Amy, but there's nothing wrong with bicycle riding or recumbent stepper or upper body training, but there's something about walking trains walking. And if you're weak and you need to start out on a bike, that's great. But somehow you just have to get your whole body upright and erect and one foot in front of the other, because that's all we have after surgery. We pile up all of our equipment, a cardiac monitor, oxygen, just anything that we have, and they may be hooked up to an IV, and we put it on our little rollator walker and a gait belt around them, and off we go down the hallway. So, I will tell them, you will get up the very first day after surgery and you will walk. You'll probably be up in the chair the same day as surgery if you're early in the morning, and by that afternoon, you'll be up in the chair. You'll be walking to the bathroom, and then we'll progressively, with inpatient pulmonary rehab, we'll start walking you on a daily basis until you're up to walking 4 times a day while you're in the hospital after the surgery. So our surgeries here with lung volume reduction have average length of stay, I'd like to say 7 to 10 days. That's what it was for many, many years. But I think just with some kind of complications that do occur after surgery, it's probably closer to 10 to 14 days currently. And that's probably more related to these chest tubes. We talked about how this is less invasive, but patients do have chest tubes bilaterally where the surgery was performed. And many times we'll keep them in the hospital until those chest tubes are removed if they are not comfortable going home with the chest tube. But we have even new equipment now for that, and managing chest tubes at home, which is lighter weight and easier for the patient to maneuver. So if they're doing great and all we're doing for them is walking them, many times we'll send them home with the chest tube and then bring them back into the hospital to pull that chest tube later on when it's ready to come out.
It seems like there's a lot of attention for pre-op strengthening before this surgery, and then managing complications after. Is that prep work the same for the Zephyr valves procedures?
Well, that's an excellent question and a good place to kind of segue. So the workup for both procedures is ultimately the same. I do the same. Our surgeons require the same amount of testing. CT scan, complete pulmonary functions, 6-minute walk before and after, pulmonary rehab. We have a battery of lab work that we do. Their arterial blood gas has to be within certain guidelines. And that's probably more information that we need to get into now. And then we get what we call a ventilation perfusion scan, which tells us where the blood flows into the lung and compared to where the most diseased portion of the lung is. We, don't want to treat an area that has a lot of blood flow. When the air sac is damaged, then the blood flow is damaged, and then that just confirms that that's the correct target area. There's probably some other stuff that we do, but those are the basic tests that are done preliminarily. The patient has to have a strong heart. If we see that there's any cardiac issues or the patient has had a cardiac history, we do refer them to our team cardiologist and get cardiac clearance before surgery, probably more strictly looking at cardiac clearance if they're going to have lung volume reduction surgery. The endobronchial valve not being a surgical procedure, we will look at some cardiac testing, but it's usually not a problem for those patients.
So those endobronchial valves, so do those patients get that done in a surgical suite, or is that done kind of on an outpatient basis, kind of like a bronchoscopy?
Well, it is a bronchoscopy, and, across the nation, pulmonologists are being trained by the companies that make the endobronchial valves. So pulmonologists are doing these procedures, I would assume, in a bronchoscopy suite. Mm-hmm. I just happen to work with a department that is cardiovascular surgeons, cardiothoracic surgeons, and they choose to be in their environment that they're comfortable in. So we do it in the operating room. So we do it in cardiovascular operating room, and for the endobronchial valves, it is general anesthesia. So the patient is put to sleep. They're intubated with the endobronchial tube, and anesthesia takes care of that. And I think what happens is that makes it a nice controlled setting so the patient doesn't cough, and then we can monitor them very closely and control all of that throughout the entire bronchoscopy. So Amy, can you flip up the picture and let's just show everybody what an endobronchial valve looks like?
Yes.
Now, I'll just say while she's looking for this that I am going to speak about the Zephyr valve made by Pulmonx, and there it is. It is made of nitinol, which is part of a nickel metallic derivative. So some patients who are allergic to nickel may have a airway reaction, but we're not screening patients and doing allergy testing for nickel. I think some centers are, but I think it's kind of not been a problem for us. I can't say it was a problem for us. And one of the nice things about these valves, if you find that maybe someone's having an inflammatory response, they can be removed. So we've just decided as a team here that if we find that there's a problem and the patient's not tolerating the valve because of maybe the metal, we're going to just remove the valves, and the surgeon will do that. I will say that in my screening, if you get somebody that's maybe has a lot of allergies, I'll ask them, can you wear cheap earrings? Have you ever had a reaction to cheap jewelry? One of my best friends, who's a respiratory therapist, now physician assistant, was always allergic to cheap earrings. It would break her earlobes out. So, that's a sign. Or if you wear a watch band that's, kind of has that nickel alloy in it, and it breaks your wrist out, you kind of know that you're allergic to nickel. So sometimes people will be forthcoming with that. I haven't really worried about it too much. I don't think it's been too problematic, but this is the endobronchial valve. It is not a stent. People like using that term. It looks a little bit like a cardiac stent, but it's has a similar scaffolding. You can see there the way it's designed, but it's different than a stent because you can see down in the little picture in the corner, it has a little duckbill valve, and that valve opens on exhalation and it lets all that hyperinflated residual volume air out when the patient exhales, and then when the patient inhales, the valve closes and no air can go into that targeted airway. Another thing that I've learned that it's always interesting talking to patients because I'm not a mind reader, but sometimes you can just tell by the look on their face, and then they'll ask, well, how many valves am I going to get? How many valves will they put in? And I had to kind of dig a little deeper into that. So, yeah, I'd want to know how many valves are going into my body, but I think there was kind of the knowledge and hearing of friends that have cardiac stents put in. Oh, I had 2 stents put in. So you think, well, my coronary artery disease isn't too bad because my neighbor down the street, he's got 6 stents. He's really got significant coronary artery disease, so that we liken the severity of coronary artery disease to the number of stents that are placed in the heart when people have that type of intervention. But it's not the same for these endobronchial valves. It's basically related to your anatomy and the surgeon's choice of what size and diameter of the endobronchial valve that he wants to place. So as the airways branch out like the branches of a tree, the more central you are, the larger the airway is going to be. So a larger valve would go into more central, but as the on the diaphragm of the lung, as those branches go out, and you have a bifurcation and a carina in the airway, if you want to place 2 smaller ones, then you might get 2 as opposed to getting 1 valve. So it's really based on anatomy, and the surgeon decides that once he takes a look down into the lung. So let's look at that next slide, Amy, that showed the valves in the airway. So this is kind of a little picture that I found online just to explain, and you can see that there's 3 valves here, and it looks like this is in a lower lobe, which can be placed in a lower lobe. Most of the time we do upper lobe placement of valves, but that's the unique thing about the endobronchial valves as opposed to the lung volume reduction surgery. I mentioned that we only do surgery for upper lobe emphysema. Well, this is a perfect example that this particular patient, this diagram shows placing valves in a lower lobe. So in the more diffuse emphysema that we could not do the surgery for, we may be able to place endobronchial valves. So it really gives hope for those patients who were not a surgical candidate. We now can help them with the endobronchial valves. For example, if their most diseased emphysema is in a middle or a lower lobe. So that shows the air in the top circle, the air coming out, the valve opens up during exhalation, and then when the patient takes a breath in, the valve closes, and you can see the little swirly arrows diverting the air to a different part of the lung. So that's how the valves work. Any questions, Kelly? You've had great questions.
Thanks. No, that was very informative. I'm just thinking of our audience and also other respiratory therapists that may listen in, that may be looking to acquire an additional skill placing these valves in a bronchoscopy suite, as you said, or maybe even the OR, if that's where the surgeon's comfortable. But I think the next thing I think we were going to ask you about is lung transplantation. You guys do lung transplants where you are?
We do not, but we will refer patients if they get to the point where that would be their next step in the process.
So what does that normally look like with somebody that you're working with? When would you normally refer somebody for a lung transplant?
I think when they've exhausted all of these other measures, good medical management, the use of oxygen, going to pulmonary rehab, are they a candidate for a lung volume reduction surgery? Have they had endobronchial valves? Now, I have to kind of go back to my endobronchial valve story again before we get to lung transplant. When the valves were approved in 2019 by the FDA, we had been placing valves for many years here. Dr. Hazelrig was actually a part of a couple of the research studies that got to the point to get the FDA to approve and then insurance to approve the placement of the valves. But what's interesting is currently they're only approved, and I say that by insurance coverage, to place valves in one lung or the other. So we've placed valves, let's say, in a right upper lobe. The patient goes along, really helps them out, 2, 3, maybe even 4 years later. The other lung gets kind of hyperinflated. So we have several patients now that we have, after a period of time, once they've met all the criteria again, hyperinflated lung, left lung looks large, they look like a good candidate, they've done well before, so we'll place endobronchial valves in that contralateral side, so patients then ultimately get that bilateral lung volume reduction that they only had one side done for those first couple of years or so. So I would think, after you've kind of gone down that road, you've had bilateral LVRS, you've had bilateral valves placed in. If your quality of life begins to, continue to deteriorate, then that referral can always be made to a facility that does lung transplant. But, many times that is an option, but, a lot of times it's really up to the patient whether they want to go that route. Just because it is another condition and another workup and a large surgery, and then a lifetime of being on anti-rejection medication. So it's really, it's something that's discussed with the patient. They can be evaluated by a center and again go through that risk benefit, here's what will happen, here's what the benefit would be to you, here's what you'll have to do to prepare yourself for that surgery. So
what are the biggest deciding factors between lung volume reduction and Zephyr valves? What would the endobronchial valves, what would the surgeon be looking for?
Well,
what should the patient do?
Yeah, let me see if I can find a picture here. So maybe you can see this. So this little photograph that I'm holding up here in front of me is a Stratix report. We get that based on the images from the CT scan. We send that off electronically and privately, and they send back a report like this, which in this particular case, this pretend patient here has the most damage in their lower lobes. You can see that they look gray instead of the white upper lobe. And so we're looking at where the destruction, a target lobe, and then we're looking to see that we can section off that portion of the lung with the valves. because this line is called a Fisher line, it has to be a pretty solid line. I tell patients you can either have a Fisher line that's like a concrete wall, like a security fence, or like a chain link fence. And if it's like a chain link fence, you're probably not going to be a candidate because air is just going to circulate through the lung. And so then we would look a different avenue for them. And recently, I've just referred 2 patients to a clinical trial at Northwestern where they're working with placing an AeroSeal product into the Fisher line. We're like it's like glue. We're saying glue, something to make the Fisher line more solid. So that is hope for people who've had this, what we call collateral ventilation, that possibly if they can make that Fisher line more secure, so to speak, then maybe they could get valves. Now, I know we're running short on time here, so
what I'm hearing is there's many choices. You want to have emphysema with hyperinflation on your CAT scan. Your doctor will be involved in the choices, but it really has to do with a lot of your imaging that you're doing, and then your lifestyle choices.
And your pulmonary function, and you've got to be strong enough to go through either one of these procedures.
Well, I think this was a really good introduction into essentially what all the options are, and what that may look like for somebody who is trying to figure out what to do and their next steps within their pulmonary health journey. So thank you so much for being on. I think this was really helpful, and hopefully we'll answer some questions for people about what to expect and what they may be going through as they look at these surgical options.
I want to just say one last thing here, because this is so easy. If we have an audience from across the United States watching, I don't know where they're going to be, but there is a website. It's called, I don't know if you can see that, getcopdhelp.com. Just that simple. Getcopdhelp.com. That's it. And they can go there and fill out a request form, no matter where they're at in the United States, probably even Canada, I don't know where, but they will plug you into a center that is close to their home. I take calls from this all the time. I'll say, how did you find out about me? Well, I called into this, I found it online. I found it on Facebook. So the Pulmonx company has this set up for people to get screened anywhere they're located.
Just for completeness, Pulmonx Zephyr valves is a brand name. Are there other brand names of pulmonary valves?
There are. The other valve is called Spiration. And I'm blanking out on the company name. I'm so sorry. But we use the Spiration valve in other settings here for air leaks, for patients who've had surgery, maybe for that lung cancer where we've taken out a large portion or a lobectomy. So there are 2 companies that make the endobronchial valves.
Very good.
This has been really, really informative, Joni. Really appreciate you coming on.
Yeah. You've been a great panel, so it's been fun. I hope we can help people, even if they live in my area. If they go through this website, they can, find Springfield, Illinois, hopefully. And there are a lot of places around Illinois now that are providing the endobronchial valves. So
We have listeners all over the country because Amy's over on the East Coast, Kelly's over on the West Coast, and we have listeners on YouTube and Spotify and Apple Podcasts and all kinds of good venues.
Wonderful, wonderful. We hope we can help people breathe easier. That's been my goal my entire career as a respiratory therapist. Just, trying to improve people's quality of life.
Joni, there was one thing you said that I just want to reiterate, and that you had a patient that finished pulmonary rehab, and he said to you, I didn't think I could ever do this.
Yeah.
And I think I could almost envision an ad for pulmonary rehab,
Yeah.
with different people's faces
Yeah.
popping off. I didn't think I would ever do this. I didn't think I could do it. I didn't think I could do it.
Yeah.
But also from not just the patient's perspective, but as a respiratory therapist, if you've never had the opportunity to work in pulmonary rehab, that is the line that patients say that make it all worth it.
Yeah.
When, I've had patients that started on a treadmill at 0.5 miles an
Yeah.
hour for 30 seconds. That's all
Yeah.
they could do. But
Exactly.
we progressed them. And in the end, they all say the same thing. I never thought I would be able
Yeah.
to walk for 30 minutes.
Yeah.
And it's just such a rewarding feeling for
Yeah.
both sides. It's win-win. So
Yeah. Yeah. It is. I agree.
Well, I'll make sure that we put that link as well, the getcopdhelp.com, in the show notes, so that if anybody is listening and has never been to that website, they can just click the link, which will make it a little bit helpful for everybody. Well, thank you so much for being on.
Thank you, ladies.
have a good rest of your day.
Will do.
Bye.
Bye. Thank you so much.
Thanks.
Hi, friends. This episode of the Cozy Lung Lounge is brought to you by Hootenanny Joy, where your health and wellness take center stage. At Hootenanny Joy, we know how overwhelming it can be to stay on top of your health, especially when life gets busy or chronic illness adds challenges. That's why we've created self-study programs designed to meet you right where you are. These programs are simple, flexible, and packed with tools to help you thrive. And they come with something extra, access to a live health coach. That's me, to guide you every step of the way. Whether it's improving your sleep, learning to nourish your body, or managing stress, our programs combine proven science with practical, real-life strategies. You can work at your own pace, get the answers you need during coaching sessions, and feel confident you're making progress. Ready to take that first step? Visit hootenannyjoy.com to explore the programs and choose the one that fits your journey best. Hootenanny Joy, because your health deserves a little joy.